As we've grown the clinical trial program and portfolio here at the Huntsman Cancer Institute, we have focused on bringing some of the most exciting new therapies to our patients in the Intermountain West. While we have a relatively extensive trial portfolio, I've really pushed hard to make sure our patients have access to the antibody drug conjugates, the bispecific T-cell engagers, and the CAR T-cells. Currently, two of the trials that I'm really excited about are the KarMMa-3 and CARTITUDE-4 trials, both of which are investigating the BCMA-directed CAR T-cells. Ultimately, it's been fantastic to see the enthusiasm of our colleagues in the community and our patients about these trials. It's really allowed us to not only provide great treatment options for our patients, but it's been a great vehicle to enhance our collaborations with our colleagues. Is that these immunotherapies represent really the third vertical leap that we've seen for the treatment of myeloma. First, we had the traditional chemotherapeutics, then we had the immunomodulatory drugs and proteasome inhibitors, and now we have the CAR Ts, the antibody drug conjugates, and the bispecifics. All that said, I believe that we're really far from understanding how to best optimize these treatments and how they'll fit into our treatment algorithms going into the future. But it's safe to say that these new drugs will likely move towards the upfront setting and radically change how we approach treatment for all of our patients going into the future. Well, I think this topic opens up an enormous can of worms for the myeloma trial community, because in many cases, I think that our trial eligibility is greatly flawed. As we all know, the myeloma therapeutic space has become even more crowded in the past several years. And so it's now more than ever vitally important to show that our new drugs and combinations are associated with significant improvement in outcomes. But with that, I believe, comes more stringent eligibility criteria in patient selection. And while the strategy may give us a better idea of how well a drug performs, ultimately the applicability of these trial results for our general patient population is likely limited. And in many patients may greatly benefit from trial participation, may not have early access to those interventions. So, in the world of myeloma, we're stuck in this quagmire of defining our treatments based on the strange space of prior lines versus prior therapies and exposure and or refractoriness to specific drugs or drug classes. And while we're fortunate to have all these drugs, these great drugs really at our disposal, ultimately there's a great amount of confusion about how to best use and which patients will benefit most from all these different therapies. I think it's very much time that our trial eligibility are more inclusive. And for this reason, it's vitally important for our large organizations like ASCO and AACR to be playing a more prominent role in pushing this agenda. Yeah, so I think there's two primary challenges that I face when trying to expand trial eligibility. One's more on a global scale and the other one's a bit more in the weeds. First, globally, and this refers to one of my prior statements, is that in the complex and busy therapeutic space of myeloma, our new drugs and regimens, they must show a very significant improvement in outcomes to be practice changing. While this may come as no surprise to anybody, the primary issue here is that there's a greater motivation to investigate our therapies in patients with less aggressive disease. In doing so, we neglect to study those patients with resistant and high-risk disease. And unfortunately, these are really the patients that we continue to struggle with knowing what to do. Sure, we're greatly improving the outcomes in our more standard risk patients, but there continues to be this population of patients with greatly reduced overall survival, and we just don't yet know how to best treat these people. So then in the weeds, one of the more significant challenges that I face when I'm writing my own new protocols is how to include those patients with non-secretory disease or those without measurable disease per IMWG guidelines. While these are generally patients that are excluded from clinical trials, I'm trying really hard to include them in all of our trials that I write and that we write. But the difficulty really comes with how to most appropriately monitor response in these patients.